everyone. In this video, we will discuss about pharmacology images. Now, one thing important in pharmacology, there are not too many images. So, this will be a shorter section. Plus, you can consider this just as a revision. Do not take the load that you need to do one extra thing. So, this is just a revision what we have already studied. Clear? So, we will start. The first one, they can show you an image of some route of drug administration and you need to identify which route it is. Now, injectably, when we give a drug, parenteral route, one method is injectable, and injection mainly are of four types. They may be intramuscular, they may be subcutaneous, they may be intravenous, or they may be intradermal. So, you can identify these just by the angle, on which angle we are giving the injection on the skin. Intramuscular will be perpendicular to the skin, 90-degree angle. Subcutaneous, it is on 45-degree angle. Intravenous, you will see that the injection is going into the vein. It is very easy. The angle is around 25-degree. And whereas intradermal, it is almost parallel to the skin. So, you cannot differentiate too much. Almost parallel to the skin, it is around 10 to 15 degrees Celsius. So, intramuscular is perpendicular, 90-degree. Intradermal is almost horizontal. Whereas intravenous you can find in the vein, going inside the vein, and subcutaneous around 45-degree. Okay? So, you can take an example like this route. So, this is almost horizontal. So, this is an example of intradermal route. Okay? Now, coming to another image in which there are plasma concentration time graph shown. So, in this graph, we need to know three important parameters. One is called Cmax, second is Tmax, and third is area under the curve. So, Tmax, Cmax, area under the curve. So, first of all, what does Cmax mean? As the graph shows, it is the maximum concentration which can be obtained by giving one particular dose. Cmax, concentration max. So, we give a particular dose. So, highest concentration we can obtain is called Cmax. So, Cmax tells that how much concentration is maximum. So, that means we already discussed it is with a particular dose. So, that means if we give higher dose, Cmax will be high. If we give lower dose, Cmax will be low. So, we will give such a dose that the Cmax lies between two lines. Cmax should lie between two lines. This is known as maximum tolerable concentration. So, obviously, the concentration must be less than which can be intolerable, and it is minimum effective concentration. So, the dose should be chosen in such a way that the Cmax lies between these two lines. Clear? More important are Tmax and AUC. Tmax tells the time in which the concentration obtained is maximum. So, basically Tmax tells the rate of absorption, how quickly the drug becomes maximum in the plasma. So, it tells the rate of absorption. If Tmax of a drug is low, we can use in emergencies because quickly the drug reaches the maximum concentration. Now, AUC tells the total area. This total area is called AUC. So, AUC, area under the curve, it tells that how much total drug has come into the plasma, or simply we can say it tells about extent of absorption. So, read carefully. If they ask rate of absorption, it is Tmax. If they ask extent of absorption, it is area under the curve. Clear? So, Cmax tells maximum concentration, Tmax tells rate of absorption, and AUC tells the extent of absorption. Okay. So, this is image of another route of administration. Can you identify? It's easy one. Yes, it is a transdermal route. Transdermal route. Can you give an example of a drug which is given by transdermal route? Yes, hyoscine. Hyoscine transdermally it is applied. It is commonly applied behind the pinna for motion sickness, prophylaxis of motion sickness. Fentanyl patches are given, transdermal patches, for pain. So, transdermal route. Now, this is a graph in which there is graph between log of dose and percentage of subject responding. Yeah. So, basically it is a dose response curve. Now, in dose response curve, you need to be careful about two things. One, the dose response curve may be graded. It may be quantile. So dose response curve, basically it is log dose response curve. On the x-axis there is log of dose. Now they may be graded, they may be quantile. Graded means if on the y-axis we have grading of response, that means less response, more response, more response, more response, more response, grading of response. Like if we plot a graph between blood pressure and dose. So if a drug is lowering the blood pressure, on the y-axis we will plot how much blood pressure is lowered. It decreases the blood pressure by 5, 10, 20, 30, 40, 50. So then it is called as graded. The name says grade of response. How much grading is there? On the other hand, the quantile DRC means on the y-axis there is quantity. Quantity means the number of subjects responding. Instead of response, grade of response, there are people responding. So on the y-axis, if there are people responding, quantity of people, then it is called as quantile DRC. So this is usually done for those drugs where the response is all or none. Response is present or not present. Obviously, we cannot grade then. When if it is present or not present, then we will see how many people responded. Clear? So on the y-axis, if there are percentage of subjects responding, it is called quantile DRC. And from the quantile DRC, you can find out two important terms, which is called as ED50 and LD50. ED50 is effective dose in 50%. So in this graph, as it is shown, there is quantile DRC, and half of that, suppose this we are seeing how much in how many people the drug was effective. So at what dose 50% of people responded, that dose is called effective dose in 50%, or simply median effective dose. Similarly, at that dose where 50% of the animals die, that is called as lethal dose in 50%, or simply median lethal dose, and these doses can be calculated from the quantile DRC. Clear? So another quantile DRC we have plotted here, log dose, percentage of population responding. So we have plotted between two things. One, response, we have plotted at DRC. Then lethal response, we have plotted the DRC. So we discussed the middle point of this will be called as ED50, and middle point of this will be called as LD50. So if we divide the two, LD50 with ED50, so this parameter is known as therapeutic index. So therapeutic index is LD50 divided by ED50. Therapeutic index is LD50 by ED50. It tells about margin of safety of a drug. Margin of safety is told by therapeutic index. Means more therapeutic index, more safer drug, less therapeutic index, less safer drug. Clear? Now this is the graded DRC. So on the x-axis we have log dose, on the y-axis we have response. Grading of DRC we are doing. So we all know the left side tells about potency and height tells about efficacy. So be very careful. Potency we just noted by left and right. More left, more potent, more right, less potent. Remember, potency is the dose, determination of dose, at what dose the effect is coming. Whereas efficacy means highest response. Clear? So from the DRC, you need to tell which drug is most potent, which is most efficacious, which is least potent, which is most efficacious. So simply look at the DRC from left to right. So most left will be most potent, most right will be least potent. So if we grade according to potency, drug A is most potent, then drug B, then drug D, and drug C will be least potent. Clear? And efficacy is from high to low. Highest response, that means drug D is most efficacious, then B and C are equally efficacious, and least efficacious is drug A. Okay? Potency left to right, efficacy high to low. Now one special thing need to be remembered. Efficacy and effectiveness are not same. So if they write in the option that the drug D is most effective, this is a wrong term, because from the graph we can come to know about efficacy, not effectiveness. It is a clinical parameter, effectiveness. So if they write D is most efficacious, the term is right. But if they write D is most effective, so this is a wrong statement. Okay. Now from the DRC, again we have graded DRC. we can also come to know which type of inhibition it is, whether it is competitive inhibition or non-competitive inhibition. Just look the graph A. This is without giving any inhibitor. So this is the DRC which is without any inhibitor. Now we have given the inhibitor and again given same dose of a drug. So if the graph shifts parallel towards right, that means B type graph is seen parallel to that drug, so then it is competitive inhibitor. So competitive inhibitor shifts the graph towards right side, parallel shift is there. So basically what happens, to obtain the same response if we want to obtain, earlier we were requiring this dose, but now we are requiring this dose. That means more dose is required to get the same response. Efficacy remains same. Clear? So competitive inhibitor basically result in decrease in potency. So parallel shift to right means a decrease in potency occurs. So that is the characteristic of competitive inhibitor. Clear? On the other hand, if the graph shifts toward downwards, graph shifts downward side, but not on the right side, graph shifts downwards, this is non-competitive inhibitor. So in a non-competitive inhibitor, potency remains same, but efficacy decreases. So non-competitive inhibitor efficacy decreases, where competitive inhibitor potency decreases. So if the graph shifts toward right, parallel shift towards right, it is competitive inhibitor. If graph shifts down, it is non-competitive inhibitor. Clear? Now this is another question. They will give a strip of a drug and you need to identify what are the points written on the drug label. Okay. So what important points are written, we will try to revise. So first of all, this symbol RX is written. So this means the drug need to be given on prescription only. If a drug needs to be given only on prescription, cannot be given without prescription, this is known as, yes, Schedule H drugs. So Schedule H drugs are the drugs which require prescription. They cannot be given without prescription. Clear? The same thing is told by red line. So this red line which is present on the label, it tells that it should not be given without prescription. Clear? Remember, pharmacists which have to dispense so many drugs to so many patients, they simply bring out the strip and see red line is present. So they will ask, give me the prescription. So they can give only on prescription. Clear? Then this word IP. So there are some abbreviations written like IP, BP, USP. P means pharmacopoeia. So I means Indian pharmacopoeia. So basically it is a book where you can find details about this drug. So details about salbutamol sulfate tablet you can find in Indian pharmacopoeia. Clear? So this abbreviation means Indian pharmacopoeia. Similarly, BP means British pharmacopoeia, USP means United States pharmacopoeia. Okay. Now after that, an MFD and EXP is written. MFD means manufacturing date, EXP means expiry date. Okay. So manufacturing date is July 2014. 14 means 2014. Expiry date is June 2017. So one important thing to remember, till what date this drug can be safely used. So written is June 2017, but they ask in the exam which June, whether it is 1st June, 10th June, 15th June, what June. Clear? So here it means the last date of that month. So when they have written June 17, so that means we can use till whole of the June 2017. So last date of June, that means 30th June 2017, we can utilize this drug. Second thing, what is the shelf life of this drug? Shelf life means the total time for which this drug maximum can be stored on the shelf of a pharmacist, or simply it will be expiry date minus manufacturing date. So expiry date is 2017 June, manufacturing date was July 2014. So that means total 2014 whole of from July 14 to June 15 1 year, July 15 to June 16 2 years, and July 16 to June 17 3 years. So total 3 years is the shelf life in this example. 3 years is the shelf life of this drug in the example. Yeah? So these are the important points which are given on the drug label. Okay. Now can you identify this image? Yes, this is very clear-cut image of hand and foot syndrome. You can find the redness and swelling of hand and feet. This is hand and foot syndrome caused by which drugs? Yes, it is caused by anti-cancer drugs like 5-fluorouracil and prodrug of 5-fluorouracil, which is capecitabine. So 5-fluorouracil and capecitabine, they can cause hand and foot syndrome. Okay. Now from the image you cannot find out, but from the history you can find out this thing. This person was treated with for laryngeal cancer by radiotherapy. After 6 months, when the cancer was not responding properly, so this person was started on chemotherapy. So when the person was given chemotherapy, there was a reaction seen on those areas where earlier radiotherapy was given. So that means you can find out the redness which is present on the neck. So this is after giving chemotherapy, the reaction has occurred only at those places where earlier the radiotherapy was given. So this is known as radiation recall syndrome. Radiation recall syndrome. So name tells you can recall that this area has been given radiotherapy earlier. The question asked which drugs cause radiation recall syndrome. So mostly it is caused by doxorubicin and daunorubicin. Doxorubicin and daunorubicin, they can cause radiation recall syndrome. Another drug causing this is dactinomycin. Actinomycin D or dactinomycin is same thing. So these cause radiation recall syndrome. Okay. Next one is easy. So here basically they are showing that normally BCR ABL fusion, it lead to activation of a tyrosine kinase and which lead to uncontrolled growth of cells leading to cancers. So we have given a drug which inhibit this tyrosine kinase, and when tyrosine kinase cannot be activated, we can treat cancer. So simple question they are asking, which drugs inhibit the tyrosine kinase? So these are the drugs which end with the NIB. Drugs ending with the NIB. Here ABL BCR transfusion is there. So basically the drugs are used in chronic myeloid leukemia like imatinib. So imatinib, nilotinib like drugs, they inhibit the tyrosine kinase, and imatinib is a drug of choice for chronic myeloid leukemia, and it is also drug of choice for gastrointestinal stromal tumors. Okay. So this is the classical picture you can easily identify. Yes, this is phocomelia. Phocomelia. Teratogenic effect caused by which drug? Yes, thalidomide. So thalidomide causes phocomelia. So this is thalidomide induced teratogenic effect. So thalidomide was withdrawn earlier, long ago, because of this side effect. But recently thalidomide has come into market again. Now it is being used for multiple myeloma. Okay. Now this is a female which was given anti-cancer drug, and female developed this side effect. So can you identify which side effect is this? Yes, it is skin pigmentation. What is the special feature of this pigmentation? What it is known as? Yes, it is called as flagellated pigmentation of skin. Flagellated pigmentation. You can find out the pigmentation in the form of flagella in the form of lines. So this flagellated pigmentation, this is characteristic adverse effect of which anti-cancer drug? Yes, it is caused by bleomycin. Bleomycin, it can cause flagellated pigmentation. What is the other important side effect of bleomycin? Yes, pulmonary fibrosis. Okay. Now this is another question which had been asked. They have given this structure. This is a structure of a penicillin. So they ask at which place beta lactamase or penicillinase work. So you don't need to remember the chemical structures in detail, but in beta lactam just remember this squarish ring, the red colored ring which we have made, 4-carbon ring. So this is called as beta lactam ring. So beta lactam ring is a squarish ring. All beta lactams have this ring, whereas the second ring is extra, which is different in different beta lactams. So now tell me with your logic, if an enzyme is named as beta lactamase, so it should act on which ring? Obviously beta lactam ring. So the beta lactamase, it will be working at point A. So it is working between nitrogen and carbon. So beta lactamase work on beta lactam ring. Simply you need to remember that beta lactamase work on beta lactam ring. Clear? So now there are methods of transfer of drug resistance from one bacteria to another bacteria, so which is called horizontal transfer of drug resistance. So three major methods are there. One is this shown. So via physical contact between the two bacteria, which is known as sex pili. So physical contact or sex pili is formed between the two bacteria, and the resistance gene physically goes into the other bacteria. Clear? So this method is known as conjugation, and conjugation is the most common method of horizontal transfer of drug resistance. Okay. Then second, this is the method that this is the bacteria which is resistant. So what happens is it sends its DNA into the environment, free environmental DNA, and that free environmental DNA is picked up by the another bacteria and become resistant. So this method is known as transformation. Transformation. So you can assume that a person was having 2000 rupees note in his pocket, and he was going somewhere, and suddenly the note was dropped. So that 2000 rupees note was dropped on the road, and this another person was going through that road, and that picked up the note. Okay? So that become resistant also. And as we know that these 2000 rupees notes we will not find every day. So this is the rarest method or least common method of transfer of drug resistant transformation. Then third method is through the help of bacteriophage. So the bacteria which is already resistant, it is infected by a virus called bacteriophage. So it will take up the resistance gene, and now the same virus infect the other bacteria and transfer the resistance gene to that bacteria. This is known as transduction. Transduction. Okay. So three method of horizontal transfer of drug resistance: conjugation, transformation, and transduction. Conjugation is most common, transformation is least common. Okay. Spot diagnosis. Yes, red man syndrome. Red man syndrome caused by which drug? The answer is vancomycin. Vancomycin causes red man syndrome due to liberation of histamine. Histamine is liberated, vasodilation occurs, the person appears reddish. Red man syndrome caused by vancomycin. Vancomycin is a drug of choice for MRSA. Again, another spot diagnosis. Yes, it is Cushing syndrome. Cushing syndrome. So you can say protruded abdomen, we have this moon face, red cheeks, buffalo hump, poor wound healing. So all these features of Cushing syndrome. Cushing syndrome caused by which drug? Yes, steroids. Corticosteroids taken for prolonged periods can lead to Cushing syndrome. Okay. Now here the question is SGLT2, sodium glucose transporter 2. So this normally help in a reabsorption of sodium and glucose. So if we give a drug like Z which inhibit this transporter, so sodium will not be reabsorbed, glucose will not be reabsorbed. So that glucose will be coming in the urine. Normally no glucose is present in the urine, but when we give SGLT2 inhibitors, then glucose will be excreted in urine and it will decrease in blood. So that drug is used for diabetes mellitus. So they act by causing glucose urea. These drugs act by causing glucose urea. So what are those drugs? These drugs end with gliflozin. Gliflozin like canagliflozin, dapagliflozin, empagliflozin. So any drug ending with gliflozin, it act by causing glucose urea due to inhibition of SGLT2. And you can remember from the name, if we write urine at the end, everything will be clear. So it says that gli means glucose flows in urine. So after giving these drugs, glucose will flow in urine. So glucose urea occur. So in the blood, urine glucose will decrease. And because the glucose has come in the urine, so the bacteria will also reach to eat that glucose. So the most common side effect of these drugs are urogenital infection. So urinary tract and genital tract infections are very common. Clear? Next, we have glucagon like peptide 1 which is normal incretin present in the body. So whenever we take food, GLP-1 is secreted by the stomach that help to release insulin and inhibit glucagon. Clear? So in diabetes, we want to increase insulin and decrease glucagon. So we can do that by inhibiting DPP-4, which is the enzyme breaking GLP-1. So GLP-1 is broken by DPP-4. If we inhibit DPP-4, GLP-1 increases, insulin is released and blood sugar decreases. And which drug inhibit DPP-4 is the question. The answer is any drug which end with gliptin. Gliptins are DPP-4 inhibitors. Examples like sitagliptin, vildagliptin, linagliptin. So many gliptins are there. These are DPP-4 inhibitors and these are the oral anti-diabetic drugs. They can be given orally. DPP-4 inhibitors. And one more question asked is, which DPP-4 inhibitor can be used in renal failure? And it is linagliptin. Linagliptin can be used in renal failure. All other gliptins are contraindicated. Linagliptin renal failure we can use. So from Hindi you can remember, अगर किडनी फेल हो गई तो भी इसको लेना है, इसलिए इसको लेनाग्लिप्टिन कहते हैं. Now moving to next image. So in this image what is shown is, there are shown many osteoclasts. So this is the osteoclast. This is the osteoclast. Now normally osteoclasts contain a receptor on their surface. This receptor is called as rank. So whenever this rank is activated, this is stimulated, the osteoclast will work. And when the osteoclast work, it will cause a resorption of bone. Bone resorption will occur. And this is activated by a ligand. This is the ligand. So normally rank bind to rank ligand. When rank ligand bind to rank, osteoclast is activated. And when osteoclast is activated, bone resorption occurs. In osteoporosis, we will want to stop bone resorption. So what we do, we make a drug in this example X. So this drug, what it do is, it is a monoclonal antibody against rank ligand. So that means rank ligand, instead of binding to rank, it start binding to this monoclonal antibody. So when rank is not able to bind to the osteoclast will not be activated. So we can stop osteoporosis. Okay? And this monoclonal antibody is known as denosumab. So denosumab is a monoclonal antibody against rank ligand. So it is used in osteoporosis. From the name you can remember, it is a monoclonal antibody for osteoporosis. Denosumab is a monoclonal antibody for osteoporosis. Clear? So this is a new drug in osteoporosis, another monoclonal antibody. This is a monoclonal antibody against a protein called as sclerostin. Sclerostin is a protein normally present in the body which promote osteoporosis or bone resorption. So sclerostin work by two methods. One, sclerostin activate osteoclast, so which causes bone resorption. Second, sclerostin also inhibit osteoblast. So sclerostin does two things. It inhibit osteoblast, so bone formation do not occur, and it stimulate osteoclast, so more resorption can occur. So if we inhibit osteosclerostin, then both of these will be reversed. So that drug is romosozumab. It is a monoclonal antibody against sclerostin. So it act by dual mechanism. It inhibit osteoclast as well as stimulate osteoblast. Inhibit osteoclast as well as stimulate osteoblast. And from the name again you can remember, it is a monoclonal antibody MAB which is used for osteoporosis. Monoclonal antibody for osteoporosis is romosozumab. It is monoclonal antibody against sclerostin. Inhibit clast, stimulate blast. Can you name another drug which has this dual activity? Only one drug extra we have. Yes, that is strontium ranelate. Strontium ranelate, it also inhibit osteoclast and stimulate osteoblast. Only these two drugs have dual activity. Clear? So there are some graphs from the autonomic nervous system. So you need to identify by looking at the effect of drugs on BP and heart rate. So in these graphs, this red line tells about the heart rate. Red line is heart rate. whereas the black line is the blood pressure. So you need to tell what is the likely drug. So this arrow is the drug we have given. So what is happening after giving the drug? The BP increases and then BP decreases. So that means by giving one dose of a drug, first BP increases, then BP decreases. So that means it is biphasic response. Biphasic response. Biphasic response is produced by which drug we discussed? Yes, it is caused by adrenaline. Adrenaline produce biphasic response. Which dose of adrenaline produce biphasic response? Low, medium, high? Yes, it is high dose adrenaline. High dose adrenaline. Remember, when we give high dose, it stimulates both alpha and beta, and due to alpha 1 stimulation, the BP increases. But when the effect starts subsiding, BP start coming toward normal. But at lower dose, only beta 2 is stimulated. They are more sensitive, so that cause vasodilation and decrease in BP. So this first increase, then decrease in BP, biphasic response of adrenaline seen with high dose of adrenaline. So here 3 drugs are given. So first is same, just before the diagram we discussed. First BP increases, then BP decreases. So this is high dose of adrenaline. Now next graph, if you see, the BP increases, heart rate decreases. After that BP becomes normal. So that means the drug is causing strong vasoconstriction, and that lead to compensatory bradycardia. So that is produced by, yes, it is caused by noradrenaline. Noradrenaline. Now moving to third drug, it decreases the BP but heart rate increases. So BP decreases, heart rate increases. This is the effect produced by isoprenaline. Isoprenaline. So adrenaline biphasic response, noradrenaline increase in BP, compensatory decrease in heart rate, and isoprenaline decrease in BP and increase in heart rate. Clear? So here what they have given is, they have given phentolamine first, phentolamine, and after some time they have given epinephrine high dose, 5 is high dose. So what happens, normally adrenaline or epinephrine, when we discussed, if we given high dose, biphasic response is seen, first BP increases, then BP decreases. But now what is happening is, after giving adrenaline, only decrease in BP is happening. BP is not increasing, only decrease happens. Okay? So that means we expected that adrenaline will first increase BP, then decrease BP. But now after giving phentolamine, that means after giving alpha blocker, only decrease occur, increase do not occur. So the effect is opposite to what we have expected. So this is known as vasomotor reversal of Dale. Vasomotor reversal of Dale. It is shown when we give alpha blocker and then we give high dose adrenaline. So BP, instead of showing biphasic response, will show only decrease. Right from the beginning it decreases. This is called vasomotor reversal of Dale. Clear? Now in this graph we have given atropine, and after that we give acetylcholine. Normally acetylcholine is a parasympathetic, so it is expected to decrease the blood pressure. But after giving acetylcholine, high dose of acetylcholine, BP and heart rate both increases. So why they increases? Yes, this is the nicotinic effect of acetylcholine. Remember, at high doses, acetylcholine can stimulate NN receptors. NN receptors. NN receptors are present in the ganglia, in sympathetic ganglia as well as parasympathetic ganglia. So at high dose, when sympathetic ganglia is stimulated, it can increase the BP and heart rate. But obviously we do not want the muscarinic effect. At high dose, muscarinic effect will also be seen. So to stop muscarinic effect, we have already given atropine. So atropine is given, so that will stop the muscarinic effect, and now high dose acetylcholine stimulate the nicotinic receptors, leading to increase in BP and heart rate. So this is nicotinic effect of acetylcholine. Okay, so we have given same dose of ephedrine, 200 first, 200 second, 200 third. Same dose of ephedrine is repeated. First the effect is very high, then the effect decreases, then the effect further decreases. This is known as, so if the same dose is not producing similar effect keep on decreasing, this is called tachyphylaxis. Tachyphylaxis. So drugs which act by displacement like tyramine, ephedrine, pseudoephedrine, they can show the phenomenon of tachyphylaxis. Tachyphylaxis simply means rapid development of tolerance. Quickly the tolerance will develop to the action of these drugs. Clear? Now this is effect of drugs on rabbit ileum experiment. So we already discussed rabbit ileum. The drug may be stimulatory to ileum, drug may be inhibitory to ileum. So they give two type of stimulatory drugs and two type of inhibitory drugs. So you need to identify actual drug which it is. The stimulatory drugs which are given, it may be parasympathomimetic drug like acetylcholine. So that stimulates the ileum. Or the drug may be directly acting drug like calcium chloride or barium chloride. So the drug may be acetylcholine like drug may be directly acting stimulant. Similarly, the inhibitory drug may also be of two types. The drug may be sympathomimetic drug like adrenal, or the drug may directly act without the sympathetic receptors like potassium chloride or even papaverine. So need to identify by looking at the graph which out of these four drugs it is. So simple mechanism or simple method to identify, first you need to see whether the drug is stimulatory or inhibitory. So if we see here, first we give normal acetylcholine, graph increases, then wash normal adrenaline, graph decreases, and now we give unknown drug X. So what happened? The graph goes up, means the drug is stimulatory. So the option is either acetylcholine or calcium or barium. Either the drug is acting through muscarinic receptors or it is acting directly without muscarinic receptors. So till now we are sure that the drug is stimulatory, either parasympathetic or directly acting. Now we will see after giving atropine what happened. Atropine is anticholinergic. So if atropine will stop the action, that means it is cholinergic drug. If atropine is not able to stop the action, it will be directly acting. So as simple as that. So after giving atropine, we give same drug again, still the effect increases. That means the atropine is not able to stop the action. So the drug is calcium or barium chloride, directly acting drug. Okay. You can see this graph, and now can you tell that which is the unknown drug? So unknown drug is stimulatory. So either it is acetylcholine group or it is directly acting group. Now after giving atropine, the action stops. The graph do not increase. That means atropine is able to stop the action. So atropine will stop the action of which drug? Yes, cholinergic drug like acetylcholine. So the answer here will be parasympathetic drug. Now if you see this graph, the unknown drug, it depresses the ileum. So the two options are there. Either the drug is acting through sympathetic system adrenaline or the drug is directly acting like potassium chloride. So now what we see, we give a beta blocker. So beta blocker will stop the action of which drug? Yes, sympathetic drug. So after giving beta blocker, we will check whether the effect is stopped or not. So we saw that after giving propranolol and again the same drug, the effect is stopped. The depressant effect do not come. So that means the unknown drug is adrenaline. Okay. Similarly, you can check here. Unknown drug depress the ileum. So it may be this adrenaline or it may be potassium chloride, and after giving beta blocker, effect is not stopped, still the effect goes down. So that means the unknown drug is not sympathetic drug, it cannot be adrenaline. So it will be a directly acting drug like potassium chloride or even papaverine. Okay. Now one more image that can be asked is they can give you a graph on the action potential. So this is a normal action potential control, and after giving the drug, the action potential become like this. So you need to identify which drug produces this type of effect. So we discussed in our lectures also, if the graph is, the phase 0 is slightly tilted downwards, that means the slope decreases. It is done by class 1 drugs, or we can say sodium blockers, sodium channel blockers. So class 1 or sodium channel blockers, antiarrhythmic drugs, they produce decrease in slope of phase 0. Okay. Then you need to see what happened to the action potential, this action potential. If the action potential decreases, it is 1B drug. If the action potential duration increases, it is 1A drug. And if the action potential duration is not changed, remains same, it is 1C drug. Okay. So remember, class 1A drugs are potassium channel blockers. Potassium channel blockade increase APD. Class 1B drugs are potassium channel openers. Opening of potassium channels will decrease APD, and 1C has no effect. So in this graph, this is the normal action potential, and unknown drug has decreased the APD. So the drug is class 1B. So you just need to remember the name of the drugs which are in 1A, 1B and 1C. 1A drugs are quinidine and procainamide. They are class 1A drugs. We discussed also 1A category. They are A category people, high-fi log hote hain. And in high-fi people we come is queen. Queen is high-fi. Prince is high-fi. So quinidine and procainamide, they are 1A drugs. 1B वाले जो होते हैं वो A कैटेगरी की सेवा करने के लिए बने होते हैं. B कैटेगरी के लोग हैं. सो लाइक लिग्नो के जो लेग्स दबाता है राजा के. वी हैव फेनिटोइन जो राजा को फैन देता है. Okay, so they are 1B drugs. So example here is class 1B drugs like lignocaine or phenytoin. So encanide, tocanide like drugs, they are 1C drugs. Clear? So this is an easy one. So you can see easily sodium potassium pump. The drug is inhibiting that pump. So it is, yes, it is a digoxin group of drugs. So digitalis, they act by inhibiting sodium potassium pump. Remember, digitalis or digoxin has two mechanisms. One for congestive heart failure, the main mechanism is sodium potassium pump inhibition. But for atrial fibrillation, the major mechanism of digoxin is vagomimetic effect. They decrease the conduction from atrium to ventricle. Okay, can you identify this plant? Yes, this plant is digitalis purpurea. Digitalis purpurea, the plant from which we obtain digoxin. So you can remember easily and while looking at the diagram. So the name digoxin, digitalis, digitalis contains digit, finger. So the flower of this plant is such that we can put them in fingers, digits. They can be put in the fingers. So from the look you can easily find out we can put in the fingers. So this is digitalis. And digoxin is this obtained from this plant, and digoxin is used in congestive heart failure. Clear? Easy one. Yes, it is gum hypertrophy caused by which drug? Most important, caused by phenytoin. Phenytoin can cause gum hypertrophy. Apart from phenytoin, two more drugs can cause gum hypertrophy. These are cyclosporin and calcium channel blockers. Cyclosporin and calcium channel blockers can also cause gum hypertrophy. Okay, so they can ask the mechanism of anti-epileptic drugs. So I made one image on which all the important drugs have been mentioned. So one, this A, it means sodium channel blockers. So sodium channel blockers are plenty of drugs, the important being carbamazepine, phenytoin, topiramate like drugs. They are sodium channel blockers, anti-epileptic drugs. Then which drug act on SV2A? SV2A? Yes, levetiracetam. Levetiracetam, it bind to SV2A, and we have new drug in this category called as brivaracetam. Brivaracetam, they act on SV2A, synaptic vesicular protein. Then coming to C, GAT1, GABA transporter 1 is inhibited by, yes, it is inhibited by tiagabin. Tiagabin. So as the name tells, tiagabin says it is transport inhibitor of GABA. GABA transport inhibitor tiagabin. Then number 4, D, the drug which act on GABA receptors, or we can say channels. GABA chloride channel. The drugs which work here are, yes, barbiturates and benzodiazepines. They work on GABA chloride channel complex, work through them. Then coming to E, potassium channel opener. Potassium channel opening drug is retigabin. Retigabin, it act by opening the potassium channels. Then AMPA blocker is perampanel. Perampanel. The name itself tells, the name says AMPA. AMPA become nil, AMPA nil, perampanel. These are the important anti-epileptic drugs with their mechanism. Okay, so can you identify? This is a skin pigmentation in the form of reticular meshwork. Reticular meshwork is present, skin pigmentation. So this is known as, yes, it is caused by amantadine, anti-Parkinsonism drug. The name is livedo reticularis. Livedo reticularis, pink skin pigmentation in the form of reticulum or meshwork. Livedo reticularis, adverse effect of amantadine. Okay. Now this is the image of mechanism of antiplatelet drugs. This is the easy one. So drug A inhibit thromboxane A2 formation, and thromboxane A2 formation is inhibited by, yes, it is by aspirin. So aspirin, it inhibits the formation of thromboxane A2. Here B, the drug is working on 2B3A receptors. Drug inhibits the 2B3A receptors, and the drugs like abciximab, tirofiban, and eptifibatide. Abciximab, tirofiban, and eptifibatide, they are GP2B3A antagonists. And lastly, which drug inhibits the receptor of ADP? P21Y2 is receptor of ADP, and the drug inhibiting ADP receptors are, these are ticlopidine and clopidogrel like drugs. And the mechanism of these all drugs you can remember again from the name itself. You can find thromboxane A2 contains A, so A for aspirin. Aspirin inhibits thromboxane A2. Ticlopidine and clopidogrel contains D, so it acts on ADP. ADP. Abciximab, tirofiban, and eptifibatide, they act on 2B3, and you can find out 2B3A contains A and B. So if a drug has both of them together, A and B in the name together, they are 2B3A inhibitors. Okay? Then we have one new group of drug also which act on thrombin receptors. The thrombin receptor which is present on the platelet is called as PAR1, protease activated receptor 1. So if we inhibit this receptor, we can again use the drug as antiplatelet drug, and the drug is atopaxar and vorapaxar. They are PAR, protease activated receptor 1 of thrombin. They inhibit that receptor, and again from the name you can remember these also. So their name contains PAR, PAR, protease activated receptor, and cross means antagonist. Paxars, they are PAR antagonist, thrombin antagonist. Clear? So these are the important antiplatelet drugs. So this is the classical feature of warfarin induced dermal vascular necrosis. It is dermal vascular necrosis. So when we start warfarin, for initial 1 or 2 days, it increases the risk of thrombosis, which can lead to dermal vascular necrosis. And this dermal vascular necrosis is more likely in those patients who have genetic deficiency of protein C, because warfarin first of all inhibits the protein C. It inhibits the activation of clotting as well as anti-clotting factors. So first of all, protein C may finish, which may increase the coagulation, leading to hypercoagulation or dermal vascular necrosis. Okay. So this is the another same diagram. Warfarin induced dermal vascular necrosis. When it affects the fingers, toes, then it is known as purple toe syndrome. Purple toe syndrome. So it is dermal vascular necrosis only. Early appearing side effect of warfarin. Okay. So these are the important images. So I hope you are able to revise these from the text. Thank you.